afternoon, everyone. So at the outset, none of the authors have any financial interest. I'm Dr. Pavitra Patel Balkrishnan, and the topic for my today's presentation is intense regulated pulse light therapy in averting worsening of pre-existing dry eyes following LASIK. So LASIK is one of the most common procedure which influences the post-operative tear film status, and post-operative, the dry eye affects approximately 50% of the patients at 1 week post-operatively. However, this LASIK-induced dryness is yet manageable. But what about people having dryness pre-operatively and then undergoing LASIK? It is definitely going to worsen the already existing dryness, and it will lead to suboptimal operative outcomes. So literature shows many authors have treated the worsened dry eye symptoms with the IRPL therapy, but that led to me a question that why can't we do it prior to LASIK surgery to prevent worsening of already existing dry eye symptoms? Yeah. So the research question was, can IRPL therapy be used pre-operatively in patients undergoing LASIK surgery suffering from dry eyes to prevent post-operative alleviation of dry eye symptoms? So the aim of my study was to assess the efficacy of IRPL therapy in prevention of worsening of the pre-existing dry eyes post-LASIK. So this was a prospective interventional study which included 50 eyes of 25 patients willing for LASIK surgery. In each patient, the right eye underwent 2 seatings of IRPL therapy prior to LASIK surgery, and the left eye was treated with only warm compressions along with the routine medical management. Now, all the participants provided written informed consent. Inclusion criteria was age more than 18 years, clinical signs and symptoms of MGD, willingness to continue ongoing therapy with unpreserved tear substitutes, and Fitzpatrick skin scale between 1 to 4. The exclusion criteria were any ocular diseases apart from MGD, for example, Sjogren's syndrome, previous IPL, IRPL, or thermal pulsations therapy within the past 24 months, previous ocular surgery or eyelid trauma, punctal plugs, pregnancy and breastfeeding, and any uncontrolled ocular or systemic diseases. So once the patients with dry eye were selected for undergoing LASIK surgery, a stepwise approach was followed. On day 1, to begin with, a clinical and automated assessment was done, followed by first session of IRPL therapy to the right eye and warm compressions to the left eye. Now, after 15 days, second session of IRPL therapy was given to the right eye, and warm compressions were continued for the left eye. After 3 days, bilateral LASIK surgery was done, and routine postoperative medications were given for both the eyes. After 1 month post-LASIK surgery, again, the clinical and automated assessment were repeated. Now, the clinical assessment mainly included Schirmer's test and OSDI questionnaire, which is composed of 12 simple questions. And the automated assessment included evaluation via ocular surface analyzer, which is known as EDRA, which gave us 4 parameters, namely the non-invasive breakup time, lipid layer thickness, meibography, and tear meniscus height. Now, NIBT is the time elapsed from the last blink to appearance of the first random break on the ocular surface. Normally should be more than 20 seconds. Next is the lipid layer thickness, which gives us, or which detects the colored lipids on the patient's eye and should be between 60 to 99. Next parameter was meibography, which basically gives us direct visualization of the morphology of the meibomian glands. And the last parameter was the tear meniscus height, which should be between 0.1 to 0.5 mm. So what was the treatment protocol like? IRPL treatment was given using a EI device. Patients received 2 treatment sessions performed at day 1 and day 15 in the right eye, following which the patient underwent LASIK surgery for both the eyes. Treatment intensity was determined based on the Fitzpatrick skin scale. 5 flashes were applied only on the right eye, starting from the inner canthus to the temporal region of below the lower eyelid. So what were the results? 14 out of the 25 patients were female and 11 were male. The average Schirmer score increased to 26 in the right eye and 18 in the left eye respectively. But when we compare the right and left eye, the improvement was significant only in the right eye. There was no statistical significance noted in the OSDI between the two groups because 7 of the 12 questions in the OSDI questionnaire required binocular function, and hence scores for both the groups for these questions were identical. Again, there was a significant improvement in the NIBT score, but when we compare in between the 2 eyes, it was significant only for the right eye. Again, the percentage of change in the gland loss post-LASIK surgery for both the eyes was not significant. The lipid layer thickness showed significant improvement in the right eye when compared to the left eye. And there was no significant change noted in the tear meniscus height for both the eyes. Now we achieved 6.6 in all 25 patients at 1 month post-LASIK. And there was no immediate DLK noted in the right eye. However, 2 left eyes developed DLK in the immediate postoperative period. Now, there are various clinical studies about the use of IRPL treatment. So, in our study, patients showed significant improvement in both the eyes for NEBUT, lipid layer as well as subjective. However, it was significant only in the right eye. And the parameters which didn't show any improvement was meibomian gland loss and tear film height. So what was known was IRPL has good outcomes in MGD-related dry eyes, and LASIK surgery causes increased dryness. So what new does this study add? It is one of its kind to use IRPL therapy in dry eye patients prior to LASIK. It compares the efficacy of IRPL therapy versus warm compressions in contralateral eyes. It emphasizes that a healthy ocular surface prior to LASIK leads to optimal visual outcomes and alleviates the dry eye symptoms. Thank you.
Excellent. Can I ask you a question?
Yeah.
Which were the patients which you did, which you labeled as dry eye, where you did the IRPL therapy?
Based on the clinical and the automated assessment.
Yeah, so what was the
for
T-BUT
example,
cutoff?
Shermer's, the cutoff was less than 10. We included all mild, moderate. It was not
Yes.
particularly only for the severe category. So it was a combined category, but basically they were diagnosed as dry eye. So Shermer's less than 10, on OSDI score of less than 15, and an automated assessment, again, NEBUT values of less than 20, because more than 20 was the cutoff for NEBUT. So accordingly, whatever cutoffs were, whatever we had given the cutoff value, anything less than that, we had.
But if it's a patient who has very severe, you would not do LASIK anyways, right?
No, that is why the therapy, that is why the role of therapy, that we
No,
gave
what-
IRP.
Yeah, there would be
how-
some subset of patients where you would not do LASIK. I mean, and even for the other eye, where you have not done the IRPL therapy.
Yeah, so that was a contralateral study, so obviously.
Another thing is, how does it differentiate from giving the treatment pre-operative and giving it post-operative?
So it reduce-
Identifying the things and do it post-operative.
Basically, pre-operatively, if we already know that the patient is a dry eye patient and patient is willing
See,
for
that we already know,
Yeah,
post-LASIK
yeah.
patient is going to suffer from dry eyes.
Yeah, but
That doesn't mean we stop treatment for that, no?
No, medical management was there for both the eyes, so pre-operatively and post-operatively. But in addition to that, we gave IRPL sitting in one of the eyes to see pre-operatively, to see how they are improving post-operatively. By giving that extra IRPL therapy, what was the improvement like?
What is the usual schedule? 3 sittings are usually
sittings,
required.
the
So
third-
here we
yeah,
have done only
only
2.
two
And did you
sittings.
do the third one post LASIK or no?
We did not do. No.
And the effects are usually seen 4 to 8 weeks later.
Yeah,
So
we
here
had,
now
4
4
months,
weeks. So
yeah, 4
maybe
weeks.
after one
Yeah,
more
yeah.
month, maybe the results would be a little
Maybe
different.
yeah.
Or maybe they achieve the same state.
Maybe. So we need to have a little long term. So you should see at 4 weeks as well as for 8 weeks. And with a complete therapy, there's no hurry to go in for surgery.
Yeah.
So maybe you could have completed all the 3 sittings to give them the best results.
Correct.
Thank you.